It's time for another warm-up. Let's get going. What is the ECG axis given the QRS deflections in each of the following scenarios? So if we have positive in lead 1, positive in lead 2, automatically you're going to think normal axis. If you have negative in lead 1, positive in lead 3, you want to think of right axis deviation. If you're positive in lead 1, negative in AVR, again, that's going to be normal axis. Next, which antiarrhythmic has the side effect of synchronism? The answer here is going to be quinidine. Next, which stain is required to see each of the following organisms? So first we have Cryptococcus neoformans. You're going to use India ink. For Pneumocystis jirovecii, that's going to be a silver stain. And for Chlamydia trachomatis, you're going to use the Giemsa stain. All right, that's it for the warm-up. Let's get to that lecture.
In this video, we're going to discuss immunodeficiency diseases, which are a 5-star topic for Step 1. You should expect at least 2 or 3 questions on these. And I'm going to highlight the high-yield details that you really need to know so you don't get bogged down in unnecessary stuff. In fact, everything you need to know about these diseases for Step 1 is found in your study guide. The first group of disorders we're going to talk about are T-cell disorders, starting with thymic aplasia or DeGeorge syndrome. Now, thymic aplasia is one of the highest yield immunodeficiencies for Step 1. DeGeorge syndrome occurs when the 3rd and 4th pharyngeal pouches fail to develop, which means you have no thymus and no parathyroid glands. Now, because there's no thymus, the T cells can't mature. That's why this is a T cell deficiency. And because there are no parathyroid glands, there's no parathyroid hormone, which results in hypocalcemia and tetany. Now, what physical exam findings might be present in a patient with hypocalcemia? Well, there's Schwastek sign and Trousseau sign. Schwastek sign is where you tap on the patient's cheek and that causes a facial muscle spasm. You can remember CH for cheek and CH for Schwastek. And then Trousseau sign is where you tighten the blood pressure cuff on the arm for a minute or so, and that leads to spasm in the arm called carpopedal spasm. So remember T for Trousseau and T for tighten the cuff. And both of those, Schwastek sign and Trousseau sign, are signs of hypocalcemia. But because there are no mature T cells, these patients have recurrent viral, fungal, and protozoal infections. DeGeorge syndrome is also associated with congenital defects of the heart and congenital defects of the great vessels. And about 90% of these patients have a chromosome 22q11 deletion. So most of these DeGeorge patients have this chromosomal deletion, but not all of them. And you can detect this chromosome deletion with fluorescent in situ hybridization, or FISH. We're going to discuss the FISH test in biochemistry. There are a few other T-cell deficiencies which are generally much lower yield. There's a disease called chronic mucocutaneous candidiasis, which is a disease of T-cell dysfunction that specifically causes problems with Candida albicans infection. We treat these patients with ketoconazole so they don't get Candida. There's another T-cell disorder called IL-12 receptor deficiency. IL-12 is produced by macrophages and it induces T helper 0 cells to differentiate into T helper 1 cells. So if the naive T helper 0 cells are missing that IL-12 receptor, the T cells won't differentiate correctly, and that leads to increased susceptibility to mycobacterial infections and fungal infections. Next, let's discuss some B-cell deficiency disorders, starting with Bruton agammaglobulinemia. Now, this is an X-linked disease, so it's mainly seen in boys. You can use the B in Bruton to remind you that this is a B-cell deficiency, and it's seen in boys, B for boy. It's caused by a mutation in a tyrosine kinase gene, and that leads to low levels of all immunoglobulin isotypes. This causes recurrent bacterial infections after 3 to 6 months of age, because for the first few months of life, these patients are protected by mom's IgG antibodies. So remember, B for Bruton, B for boys, B for B cells, and B for bacterial infections. In Bruton agammaglobulinemia, you have low levels of all immunoglobulin isotypes. But some patients have selective immunoglobulin deficiencies in which there's deficiency of a specific immunoglobulin isotype. The one you're most likely to be tested on is selective IgA deficiency. Most of these patients appear fairly healthy enough that they aren't really aware there's a major immunodeficiency going on. All they know is they have recurrent sinus infections and lung infections. Remember, secretory IgA is found in mucus, and it's important for protecting the respiratory tract from invading pathogens. So if on your test they give you a young adult who gets sinusitis 3 or 4 times a year or has several bouts of pneumonia, think about the possibility of IgA deficiency. Selective IgA deficiency affects about 1 out of every 600 people of European descent. It's associated with atopy and asthma, so these patients are more likely to have allergies and asthma and eczema. but there's not much you can really do to treat it other than having a lower threshold for prescribing antibiotics. But it's important to diagnose IgA deficiency because these patients can potentially have anaphylaxis to blood transfusions and blood products. So if you have a patient with this diagnosis who needs a transfusion, you can pre-treat them to prevent the anaphylactic reaction. Let's discuss immunodeficiency disorders that affect both B cells and T cells. One important one is called SCID, or severe combined immunodeficiency. So that should give you a hint that it's a combined B cell and T cell deficiency. This is caused by a defect in early stem cell differentiation, and there are at least 7 different gene defects that can lead to this. But the main defect worth knowing for step 1 is the adenosine deaminase deficiency. We're going to see that again in biochemistry when we review the purine salvage pathway. Patients with SCID are deficient in both B cells and T cells, which means the last line of defense is the natural killer cells. SCID presents with a classic triad that includes severe recurrent infection, specifically chronic mucocutaneous candidiasis, fatal or recurrent viral infections like RSV, varicella-zoster virus, herpes simplex, measles, flu, or parainfluenza, and also pneumocystis pneumonia, or PCP. The second part of the triad is chronic diarrhea, and the third part is failure to thrive. So know that triad: recurrent infections, chronic diarrhea, and failure to thrive. Another good clue for the diagnosis of SCID is the absence of the thymus. A newborn chest x-ray will show no thymic shadow. That's a good clue. In newborns, the thymus is normally pretty large because they have lots of T cells developing. Another immunodeficiency in which you wouldn't see a thymic shadow is DeGeorge syndrome because these patients have thymic aplasia. The thymus doesn't develop. Another combined B and T cell deficiency is ataxia telangiectasia, which is another one you need to be very familiar with. This one has several unique features. Ataxia telangiectasia is associated with deficiency of IgA, so you can remember A for ataxia and A for IgA. And then in addition to the IgA deficiency, there's also a problem with T cells and cellular immunity. And this leads to sinus and lung infections, just like with selective IgA deficiency. This is called ataxia telangiectasia because these patients exhibit cerebellar ataxia. They also have poor, smooth pursuit of a moving target with the eyes. So if there's an object moving across the visual field, the patient's going to have a hard time following that object with their eyes. And that's called poor, smooth pursuit. These patients also have telangiectasias, specifically telangiectasias on the face, but not until after the age of 5. Ataxial telangiectasia is a disorder of defective DNA repair, so these patients are sensitive to radiation. Radiation damages DNA, and then these patients have a hard time repairing that damage. So if possible, they should avoid X-rays. And they also have an increased risk of lymphoma and acute leukemias. So if you see a toddler with ataxia or poor smooth pursuit, you really want to be able to make an accurate diagnosis so that you can then monitor that patient for leukemia. And AFP is usually elevated in these kids after 8 months of age, and that can be useful for screening. So in that toddler with poor smooth pursuit, you might check the AFP level. So remember, A for ataxia, A for IgA deficiency, and A for AFP. Now a student sent us a mnemonic for the features of ataxia telangiectasia, which is simply the word ataxia. The A and T are for ataxia and telangiectasia. You can also let the T stand for tracking eye difficulties for that poor smooth pursuit. The other A is for acute leukemia and lymphoma. The X is for X-ray sensitivity. The I is for IgA deficiency. And the final A is for AFP. Another combined B and T cell deficiency is Wiskott-Aldrich syndrome. And the mnemonic for this one is the word waiter. That stands for Wiskott-Aldrich, immunodeficiency, thrombocytopenia and purpura, eczema, and recurrent pyogenic infections. Now, Wiskott-Aldrich is another X-linked disorder, so this is going to affect boys. And these boys don't have any IgM against bacterial capsular polysaccharides. They have low IgM levels and high IgA levels. And the last one is hyper-IgM syndrome, which is one of the lower yield ones. With hyper-IgM syndrome, you have too much IgM production, but decreased production of the other antibody isotypes. But stop and think. If this is a problem with immunoglobulins, wouldn't that make this a B cell disorder? Well, actually, there are several different genetic defects that result in this phenotype with different inheritance patterns. There's an autosomal recessive variety where the B cells lack the CD40 surface marker. Remember that CD40 binds to the CD40 ligand on helper T cells in order to promote immunoglobulin class switching. So if there's no CD40, there's going to be less class switching, and basically all you get is lots and lots of IgM. But the more common variety of hyper-IgM syndrome is an X-linked variety in which the T cells are missing the CD40 ligand. That's why it's a B and T cell dysfunction. Finally, let's review a few immunodeficiency disorders that affect the phagocytes, especially neutrophils. The first one is chronic granulomatous disease, which is definitely high yield. There are several different genetic defects that can cause this phenotype, but the most common one is an X-linked mutation. The underlying problem is a lack of NADPH oxidase, which is the enzyme that generates superoxide free radicals. So phagocytes are supposed to be able to engulf pathogens and debris and then destroy them. But because these phagocytes lack NADPH oxidase, they can't generate free radicals, so they can't kill microbes that are catalase positive. That means these patients are especially susceptible to infections with Staph aureus and Aspergillus. So make sure you know the enzyme that's deficient, NADPH oxidase, and make sure you know those two pathogens, Staph aureus and Aspergillus. You should also know how we diagnose chronic granulomatous disease. There's a really old lab test called a nitroblue tetrazolium test, where you add a dye called nitroblue tetrazolium to a sample of the patient's blood, and the phagocytes take up this dye. And normally, phagocytes that are able to generate oxygen-free radicals will oxidize the dye so that it turns from yellow to kind of a blue-black color. On the left side of this drawing, you see what it looks like before the dye has been instilled. And on the right, the phagocytes have oxidized the nitroblue tetrazolium to a blue-black pigment. And that's a positive nitroblue tetrazolium test. That's normal. But in chronic granulomatous disease, the phagocytes can't generate oxygen-free radicals, so they can't oxidize this dye, so the phagocytes don't turn blue. That's a negative nitroblue tetrazolium test, and that's one way to diagnose chronic granulomatous disease. There's also a newer test using a fluorescent dye and some Western blot testing, but the NBT test is the classic one, and that's the one you ought to know for step 1. And then to treat chronic granulomatous disease, we give prophylactic trimethoprim sulfamethoxazole and prophylactic itraconazole. And interferon gamma is also helpful in the treatment, although the mechanism of action isn't really understood. Next is Shaydak-Higashi disease. This is caused by a defect in the LIST gene, the lysosomal transport gene, which is important for transporting enzymes into the lysosomes. If you can't get enzymes into the lysosomes, the phagocyte lysosomes are defective. They won't work. So the neutrophils can engulf things, they just can't digest them. So inside the neutrophils, you'll see giant cytoplasmic granules. These granules are big lysosomes that are full of stuff that just can't be digested and destroyed. You need to be able to recognize the classic triad of Shaydak-Higashi disease, which is partial albinism, recurrent respiratory tract and skin infections, and a variety of neurologic disorders, everything from peripheral neuropathy to ataxia to seizures. A student sent us this quick mnemonic for the triad of Shaydak-Higashi syndrome, which he called the pain triangle. So the PA in pain is for partial albinism, the I is for infections, and the N is for neurologic disorders. And then you draw some dots inside the triangle to remind you of the cytoplasmic granules that accumulate inside the neutrophils. Let's also briefly mention a very rare disorder called hyper-IgE syndrome. The older name for this is Job syndrome, like Job from the Bible. Hyper-IgE syndrome is probably an unfortunate name because while IgE levels are high, that's not really the main cause of the immunodeficiency. Hyper-IgE syndrome is caused by a mutation in the gene for a signaling protein called STAT3, which is part of the Janus kinase signaling pathway, or JAK-STAT pathway. And this leads to two main immune system problems: impaired differentiation of T helper 17 cells and impaired recruitment of neutrophils. And we haven't talked about T helper 17 cells because they aren't very well understood and because they aren't high yield for step 1. But T helper 17 cells live in the mucosa and they produce cytokines that recruit neutrophils to fight opportunistic infections like staph and candida. So some review books classify hyper-IgE syndrome as a T cell disorder, but I think it's useful to group it with the phagocyte and neutrophil disorders. And these patients also have high levels of IgE and eosinophils, but we really don't understand why. The clinical triad for hyper-IgE syndrome is eczema. You can remember E for eczema and the E for IgE. Recurrent cold abscesses. These are Staph aureus abscesses. This disease was first called Job syndrome because these patients were covered with boils like Job in the Bible. And why are these cold abscesses? Well, you have a walled-off area of infection, but the neutrophils can't get in there, so there's not an appropriate inflammatory response. So these aren't hot abscesses, these are cold abscesses. These patients also have coarse facial features, such as a broad nose, a prominent forehead, which is called frontal bossing, deep-set eyes, and thick or doughy skin. These patients can also retain their primary teeth, so they have 2 rows of teeth on top and 2 rows on bottom. And if you see that, think hyper-IgE syndrome. One last disorder is called leukocyte adhesion deficiency syndrome. The main thing I want you to know about this one is that you have abnormal integrins. Integrins are the molecules that help leukocytes exit the circulation and then integrate into the interstitium. But with abnormal integrins, phagocytes can't leave the circulation. And one of the ways this presents, in addition to recurrent bacterial infections, is delayed separation of the umbilical cord, which is basically a manifestation of impaired wound healing. So if they give you an infant where the umbilical cord hasn't fallen off after a couple of months, think about leukocyte adhesion deficiency syndrome. All right, now we're ready for the end of session quiz. So work through those questions, then we'll go over them together. First question, what are the X-linked immunodeficiencies? So we mentioned Bruton A-gamma globulinemia, chronic granulomatous disease, not always, but most of the time, Wiskott-Aldrich syndrome, most cases of SCID are X-linked, and most cases of hyper-IgM syndrome are X-linked. Next, what are the clinical features of Wiskott-Aldrich syndrome? So remember, the mnemonic for Wiskott-Aldrich is waiter. So the first two letters, W and A, are for Wiskott and Aldrich. And then you have I for immunodeficiency, T for thrombocytopenia and purpura, E for eczema, and R for recurrent pyogenic infections. And these individuals have a low IgM and high IgA. Next, what's the cause of chronic granulomatous disease, and what infections are these individuals susceptible to? So the cause of chronic granulomatous disease is the absence of NADPH oxidase, so that phagocytes can't generate oxygen-free radicals. And that makes these individuals susceptible to catalase-positive pathogens, especially Staph aureus and Aspergillus. The last question. A young child presents with tetany from hypocalcemia and candidiasis resulting from immunosuppression. So what cell type is deficient in this patient? Well, this is DeGeorge syndrome, which is a T-cell deficiency from thymic aplasia. And the hypocalcemia is due to parathyroid gland aplasia. Then we have a couple of rapid-fire facts. Eczema, recurrent cold abscesses, and high serum IgE, that's hyper-IgE syndrome or Job syndrome, and large phagosomal vesicles and neutrophils, that's Shade-Higashi disease. And that's it for now. I'll see you next time.
These two guys don't get along, but when it comes to education, they are never wrong. Yeah, if you pay attention, you might get an A. They don't like each other, but that's okay, 'cause they are bosom buddies.
Hello, and welcome to the show. I'm Dr. Lewis.
And I'm Dr. McInnes. I'm one of the chief educators here at Doctors in Training, and today we're talking about...
Whoa, hold up. I thought I was the chief educator around here.
Yes, that's the title. We're both chief educators.
But look, I've got these awesome glasses and a cool beard.
Me too!
Nice.
Anyway, today we're talking about chronic granulomatous disease.
What'd you say about my grandma?
Not grandma, granulomatous.
Granulomama?
Chronic granulomatous disease is a rare immunodeficiency disorder where the phagocytes are deficient in the enzyme NADPH oxidase. That means they can't generate oxygen-free radicals. So the phagocytes can engulf catalase-positive microbes, but they can't kill them.
Like staph or Aspergillus.
Exactly.
There are several diagnostic tests that you can use, but the test that you should remember is called the nitroblue tetrazolium test. Normally, phagocytes will take up the nitroblue tetrazolium and turn it kind of a bluish black color. But phagocytes that lack NADPH oxidase can't do this, so the nitroblue tetrazolium test is negative.
Strong work. You really are a chief educator.
Yeah, I still don't get how there can be two chiefs. What's the saying about too many cooks in the kitchen?
You mean too many cooks spoil the soup?
Soup. What's for lunch?
Never mind. See you next time.